On a typically warm Southern California day, a woman leaves her house to buy soup at the corner store. Feeling weak, with a fever and rash, and with what she assumes to be the flu, she decides to see the community health clinic. 2 days later, a second woman who lives a block away and has been irritated for about a week by a rash on her palms and the soles of her feet, decides to visit the emergency room at University Hospital. She is admitted and isolated. A disease report is generated and a case investigation initiated immediately. CDC is called and a preliminary alert goes out. Both women die. Laboratory tests confirm smallpox. By now, a third death has occurred on the East Coast and 6 more in London. It is assumed that a carrier of the disease has flown coast to coast and transcontinental. Panic becomes widespread. Both the sick and the worried will overwhelm the healthcare community. Fortunately, this outbreak has not yet occurred, but others like it have. In 1918, a migrating bird, most likely a duck, landed in a farmer's pond in Kansas. A new virus had been carried in the animal, and the duck somehow passed this on to a human. By September of that year, 6 months later, 12,000 Americans had died. There were no planes in those days, or even many cars, but there were railroads, and the disease followed these tracks west. 1 month later, 195,000 Americans had died. The disease was Spanish influenza, and it killed 650,000 Americans. Increasing and mobile populations can spread a disease faster than ever before. We never know if and when a new disease will be introduced, either intentionally or unintentionally. Disease outbreaks occur all too frequently. Public education, improved sanitation, vaccines, and healthcare prevention efforts are programs designed to minimize the impact of disease. They are not designed to provide efficient surveillance and early warning. They are not designed to adequately support emergency preparedness or incident management.
You're going to get a vaccine, okay?
Public health is committed to meeting the healthcare requirements of the community. To achieve this goal, information becomes their most important need. Every day, doctors, emergency rooms, nurses, EMTs, health, food, and agriculture inspectors collect extremely valuable information. They gather this through individual patient services and encounters. They gather this through investigation, surveillance, and case management. Information varies in detail, timeliness, and accuracy, but in all cases, information is specific to the individual's needs. Rarely is information shared, communicated, or subsequently analyzed.
Main problem I see is when they go to different doctors, different clinics, and get vaccines, there is no universal system to log them. So we still rely on the physical record that they have to bring, and many times they don't bring. So many children are skipped the vaccines because we just don't know if they had it or not. And some may even get duplicate vaccines, which we try to avoid and just not give it if they don't bring the shot records.
Does that satisfy your version 1?
If decision makers had access to all this information, and if this information was processed in a clear and effective way, then a powerful tool would exist to support early warning and preparedness. Disease specialists would know very quickly where a disease originated, who is experiencing similar symptoms, who's at risk, and how the outbreak should be handled. Shareable information to support public health decisions can be a reality. In order to achieve this, an integrated public health surveillance system linked into an epidemiologic command center is needed. A command center similar to 911 dispatch or a military mission control center, or for that matter, NASA's Shuttle Command Center. A single location where diverse threads of critical information are collected, processed, and presented to decision makers. A center where automated alerts and notifications can be sent using the established health alert networks. A center that not only supports early warning, but also executive awareness and event management.
essentially all the GSP pages have this right in there, everything. And then the database has some of that also in there. So it's split between interface.
The system would make it possible for important data collection centers, such as physicians' offices, emergency rooms, and local health clinics, to not only report their individual information, but also have access to correlated information, which would support their individual efforts as well. Integrated surveillance systems are not the norm. Consider the problem as a Rubik cube. This cube represents the current public health information resources. When a disease is suspected, decision makers do not have correlated information on which to base decisions. The trick is to solve the Rubik cube. Once solved, shareable information and resources become the norm. An integrated surveillance and command center requires processes for loading, validating, and storing information. It requires processes for identifying duplicate records and merging information. It requires processes for generating statistics, reports, and maps that illustrate past and existing impacts and project future impacts.
Y necesitas regresar en 2 días a checarlo, ¿ok?
Such an information system can be created that would allow the public health professionals to maintain their respective data and manage their users while maintaining accountability for the accuracy and timeliness of the information submitted. It would thus link these independent resources. Surveillance and data collection using Internet-based disease reporting, EMS, police, and hospital records could then be aggregated and processed. The number of people exceeding the average for a given symptom, such as the flu, could be compared to area demographic registries with the result mapped to allow health officials to determine pockets of need and at-risk populations. Public health is committed to meet the needs of a community. Health officials see this as a long-term commitment. Like teachers, they have a greater calling. They have a mission and a vision that simply does not stop at 5 p.m. every day. But public health now faces new problems as never before. The need to know is critical, and time is no longer a luxury. The ability to quickly recognize a potential outbreak, react and monitor the event, is the most important approach in continuing to protect the public health of the nation. We must take the lead by creating innovative information systems. There is, in fact, a proven roadmap for success. Bioterrorism has raised the stakes, and it is essential that we do not settle for second best. With integrated information, public health will move to the forefront in support of disease surveillance, emergency preparedness, and bioterrorism planning.